And going back to what you were saying, Rick, just this idea of an ounce of prevention being worth a pound of cure, just as important as recommending things is starting the dialogue with patients. Steve, from what you've seen in your practice, when do practitioners really discuss OIC with their patients?
Well, again, the emergency department is a skewed venue. It's when people are in with miserable pain and I've just done an exhaustive workup and I really haven't found much else. That usually brings me back to looking over their medications as part of that workup. And that's when I always have that conversation. I can tell you that I was trained quite a while ago, where they talked to me initially about anytime someone over the age of 60 gets put on an opiate, you should have that conversation right away. I'm finding now that that age is, there's no cutoff at 60. 60 is not a magic number. I start that conversation now quickly when I start opiates that I think might be longer than 2 days with people in the emergency department, because I think it's important.
Can I ask you a follow-up? I'm sure you've seen many patients who have an opioid on their list, med list, maybe started recently. How many of them have a concurrent laxative or agent of some kind?
My guess is in the emergency department early on, not many that will reveal it to me. It's certainly not one of those that when they do what's called a med reconciliation comes up. You really have to ask specifically, and then you find, just like we've heard, that a lot of them have already been aisle 5 shopping to try and find solutions themselves.
So let me add a little bit, David. I think, so I work more in a chronic outpatient setting, and I have fellows, so I always tell the fellows, you know, either any of our patients, many of whom come to us on opioids, you need to make sure you've had that conversation. It doesn't have to be a lengthy, in-depth conversation, in my opinion. I think that's where people make the mistake. I understand we're all busy practitioners and we have a lot of work to do, but you usually can get to the heart of this with patients in 1 or 2 questions. I also tell my colleagues or the fellows when they're going out into their own practices, make sure you put it on the questionnaire somewhere so the patient, while some of them may not, it's not reliable for all patients, certainly some will circle if constipation's a problem, and sometimes if they're too embarrassed that way. I do also think you ought to certainly have that conversation when you start an opioid on a patient, right? So don't wait till they come back or that they're not going to talk about it. None of the drugs we're going to talk about that are approved for OIC have a prevention indication for OIC, but that doesn't mean we shouldn't, as clinicians, talk to patients about OIC when they first get an opioid, so that they are at least aware, and also so that they're not surprised by it, right? And in fact, you should say, look, if you do develop it, which is pretty doggone common, maybe as much as 80 or 90% of the people on opioids, there are treatments for it, and you don't have to just stop the drug if you get that side effect.
There's the tape that I roll out of my brain every time I prescribe an opioid, and I didn't necessarily do it 10 years ago, but now if I prescribe it, I talk a little bit about the risk of addiction, the risk of other things, but I mention the complications. And as you said, it's 1 or 2 extra sentences, and it's worth it.
You know, it's interesting because we've been talking about opiate-induced constipation and the importance of, you know, educating our patients, talking to our colleagues for decades. And to fall back on a comment that Brett made about even now, prescribing opiates requires so much more education when you start a patient about addiction, about safety in the household, and all of that. I think that the OIC question and comments are getting, you know, pushed farther and farther down. Yeah. So it's just, again, reminding ourselves what we need to do and and normalize it. Make the condition a one of normal discussion.
We're going to come back and say over and over again, remove the stigma, because that's really important.
Normalizing it is so important. We've heard that it can be a sensitive topic. People can feel anxious about this. We've also heard that constipation itself is almost a nebulous term for the public. If even with our criteria, there's so many elements of it. I'm curious, Brett, kind of in your practice, how do you address a patient who may be kind of embarrassed to talk about this or doesn't even know how to begin talking about this with you?
Well, you said embarrassed, and that's always interesting. It's not a sexy topic, and that's what I've said from day one. It's not erectile dysfunction. I mean, whoever thought we would have these conversations very openly with providers and men be okay to have these conversations? But you talk about constipation, and men drop their head, and it's men more than women drop their head and don't want to have the conversation. And it will take a visit or two after you continue asking that question for them to say, yeah, this is a problem. So I think it's a reluctance in a population, not just men, but again, it's not a topic everybody wants to talk about. And sometimes, again, the first conversation, people say, oh, it's fine. But in all reality, it's not. So there's a reluctance. And I think it's just that ongoing dialogue that no, at every visit, we're going to talk about this along with everything else. Again, it's putting it in order of saying, yes, this is important. We know it's the most common side effect. We know respiratory depression and concern for overdose, least common, most serious. So, I think, again, it's just making certain, one, it's a dialogue that you're going to continually have, and then that comfort level builds there to have the conversation.
Absolutely, kind of finding your own words to be comfortable with it. But the most important thing is just, I guess, having the courage and foresight to even plan and engage in that conversation, not waiting for your patients to take initiative with you.